Thank you. I think I'm sure you all are looking forward to the end of this and a drink. So let's see if we can get there. I really appreciate Robert's words as well, because I think he very effectively described a few things that HIA done well works, and then maybe that done well it is something we need to add. And yet HIA builds a capacity to do more and to be effective and potentially put itself out of business in a better sort of future world. And I think that's where I'm going to sort of pick up on the end of Robert's conversation and sort of move it forward. I'm not by training or by nature a health impact assessment practitioner. I'm a physician, a public health practitioner, a population health practitioner. And our goals, and I think that the goals that are shared by many of you, are multiple. We want better public policy making. We want better environmental conditions, social justice, collaboration, inclusive social participation, accountable political systems, and consensus. How do we achieve this? In many ways. And like you, one of the ways we picked up to achieve these multiple aims was health impact assessment. I think one of the brilliant things about health impact assessment is that it can achieve all of those aims. And that is, it makes it a really brilliant, beautiful practice. Robert talked about multiple types of outcomes from health impact assessment. We've done about 20 plus health impact assessments in San Francisco, and we saw many of the same outcomes. I want to focus, though, on what health impact did to us as a group of public health practitioners. What it did was it created relevance for our agency, our work, and the idea of health determinants. It allowed and catalyzed our participation in a variety of policy networks. It created, through health impact assessment, we created a system of measurement for all of the social and environmental and economic determinants of health for San Francisco, and we've maintained that system of measurement. And it created an opportunity for us to effectively engage in interinstitutional practices. All of those practices in every stage of the design, of every stage of the process. If we had had rigorous quantitative evaluation of our work over 10 years, the graph might look like this. The red is the number of HIAs, where there was a peak representing, I think, sort of the peak of learning and relationship development, and then sort of a drop-off. And I think we now do few health impact assessments, but we still do them. Over time, relationships and collaborations and partnerships built. And over time, and exponentially, information and knowledge sharing of health information is growing. And we fully expect both the relationships and the knowledge sharing to continue to grow. And that capacity that HIA built really catalyzed and triggered this work. A few examples. The research measures that we were using to do health impact assessment and public health epidemiology, we've been able to translate into performance measures for our sister institutions. One example is measures of the density of pedestrian injuries on streets. And by creatively looking and presenting these measures in ways that might have influence. For example, we translated the injury measures into a measure of injury density per mile. And we were able to show that 5% of the miles accounted for 55% of the serious injuries. And this was a map that was just gobbled up by our sister agencies. The Transportation Agency says 5% of the streets, we can handle that. We're going to have to change our practices, focus on the arterials a little bit more, think about new techniques. The police department now has this map up in every one of the precincts, and the police officers have been directed to go and do enforcement where these blue lines, these dangerous lines are. It's focused public financing on these streets, and we learned both how to figure out how to provide the relevant evidence, and we developed the capacity to produce that evidence through the skills building from health impact assessment. From policy analysis, we've also gone to policy development and implementation. As the public health agency, we have a role in law development and regulation. One of the things we learned through doing health impact assessment is there is no law that protects new buildings from air quality impacts that they get from a nearby air pollution source. We sometimes try to control the source, but we don't protect the interior environment. The streets, there is no rule, the streets are not treated as the factories that they are in creating air pollution. No law existed, so we could have waited for the law to come around and then do the health impact assessment, but we realized we had the obligation, the ability, the responsibility to write and develop that law. And through the health impact assessment, we had developed the community and agency partnership network in order to do just that, and we were able to develop the first law to do this in the United States. What population health needs is engagement at all phases of the policy cycle. We're not just reacting with health impact assessment, but we can be defining what the problems are, where the gaps are. We can be setting the policy agenda, and I think strategic health impact assessment can do that. We also must focus on implementation. There are laws and laws and laws that are just not enforced. If we could spend a little time enforcing the laws that are supposed to protect public health that are not enforced, we would do probably a great deal of good. And we can't, and therefore we can't just, I think there's a very attractiveness about new policy. I developed a new policy, I influenced a new policy, but there is old policy that no one is being accountable for that needs attention as well. I mentioned strategic uses of health impact assessment. I mentioned that we're still doing a trickle of health impact assessments, a few a year. And here are some, I mean, I think the characteristics now we're looking for. We don't do health impact assessments on land use or transportation plans or projects anymore because we can directly influence the design and development of those projects. We're thinking about opportunities in policy to be anticipatory and provocative, to identify the important, use HIA to identify and answer some new policy questions that aren't on the agenda. We think of policy opportunities where there are multiple questions to answer in terms of policy design or implementation. We think of opportunities where there are multiple decision targets at multiple scales of government. We think about network building and we think about organizational learning in the selection. I think the factors in retrospect that have most contributed to effectiveness is we didn't try to create a new public health agenda. We worked on the existing priorities of the agencies and our communities and the residents. There's enough of a political agenda out there to work on and relate to. We don't have an obesity agenda. I don't have an obesity agenda in San Francisco. We found ways to be helpful to both interest groups and public agencies. We were greeted with skepticism at first, but I think with being sincere and being helpful, we were found to be helpful and ultimately created a constituency for our practice. We brought data and scientific credibility to controversies, which ended up being very helpful. We recognized that there was a great deal of authority. As a public health officer, if there's a health issue and I'm silent and harm happens, I'm responsible and accountable for being silent. Silence is a problem, and we are expected to speak when there is a problem. And I don't think that we often realize how much we are expected to speak up. We focused equally on technical capacity and relationship building. We used existing processes instead of a mandate for some new process. We kept HIA internal as a technique. And I think we're clearly committed to the long-term ends and instead of the technical means. We learned some pretty simple things of what decision makers want, and I think that these are things in a sense, we all want, and in a sense, we are all decision makers. They want value and benefit for their constituencies. They want measurable and tangible results. They want limited controversy, no surprises, limited red tape, and solutions and not problems. And whatever we call the work we do, we need to understand this and try to navigate this and try to provide this. Solutions are important. They trusted that we knew what the problems were. They never questioned the evidence or asked for better evidence, but they said, how are you going to solve this? The implications for population health and health impact assessment practitioners that I think are important. HIA may serve multiple purposes at different times over time as it develops and evolves in a place. Alternatives to health impact assessments can be much more efficient and effective where the collaboration and accountability systems exist, but maybe you need HIA to catalyze those collaboration and accountability systems. The use of HIA needs to exist only as part of a larger system of public health participation in the policy process. It can't be the only thing. There's got to be choices. Data systems and relationships with and understanding of partner agencies must be core competencies and capacities for public health agencies. And last, we need the flexibility to act in ways that don't necessarily, that I can't count in terms of public health metrics at the end of the day. A view, sort of a last thing, and just a sort of a view to the future, or at least where I'm trying to go in the future. Health impact assessment, we've often, I think, is a vehicle to carry health information as well as community needs and priorities into the policymaking process. Well, let's make that direct. We can make that direct if we can take the data and evidence that we're using and directly provide it in useful, understandable, consumable ways to the public. And I know that raises lots of issues of equity and who gets the information and how they can get it. But I think if we can think into the future in this digital communicative age, we need to be thinking that as the direct route. We're currently trying to open our data sources, everything we've collected, to the public. We're supporting private, creative data applications and and then we're going to be thinking about acquiring new public source data sets. So I'll end there. Thank you very much.